Good afternoon, Dr. Rania. Your mic, can you please mute off the mic, please?
Good afternoon, ma'am.
How are you?
I'm fine, ma'am. How are you?
All good. So I'm so excited to have you today.
I'm excited to present this case here, and thank you
Lovely.
for providing me the opportunity to do so.
Lovely. So let's start with the session. I think it's already 12. Let's start with the
Yes,
session. So hello everyone. Good afternoon to all of you. Welcome to today's online webinar. It's a pleasure to have you all join us for this insightful session. My name is Dr. Niharika Jain Gupta, and I'll be your host for today's event. I welcome you all to the fourth episode of One Among You, which is a proud initiative by Epistate Health Singapore. So the idea of the idea of for coming up with this type of event known as One Among You is to invite passionate dentists like Dr. Rania, Dr. Sunil, and so many other
thank you.
passionate dentists who do wonderful cases to come up and share their expertise with us, which will be very useful for everybody, for all the clinical practitioners out there. And I'm quite sure of this. So, we are excited to present a short yet engaging case presentation, which is focused on non surgical endodontic treatment of mandibular molar, especially mandibular third molar, which is quite tricky. So the session is designed to provide you all with practical insights, tips and strategies that you can apply in your clinical practice. Whether you are an experienced endodontist, a routine dentist, a clinician, or a dental surgeon, I hope this presentation will definitely be informative and inspiring. So before we dive into the case, I would like to extend a warm thank you and welcome our speaker of fourth episode of One Among You by Epistate Health Singapore. And she is a beautiful lady, beautiful
Thank you so
endodontist,
much.
a would-be endodontist, Dr. Rania. She's a second year postgraduate, right, Dr. Rania?
Yes, yes, ma'am.
Yeah, so she's a second year postgraduate from Rajiv Gandhi Institute of Dental Sciences. And Dr. Rania completed her BDS from Krishnadeva Raya Institute of Dental Sciences. So we extend warm welcome to Dr. Rania.
Thank you so much, ma'am.
Uh,
That
and we encourage all of you, just a minute, there's some problem. Yeah, we encourage all of you to actively participate by asking questions or sharing your thoughts in the chat box during the Q&A session in the end. So if you have any doubts, please feel free to type your questions in the Q&A chat box. Your engagement will definitely make this webinar even more enriching for everyone. So without further ado, let's get started. Dr. Rania, the floor is all yours. Thank you and enjoy the session. Also, one
thank
more thing, the recording of this session will be available online on our YouTube channel. So please, and if you have any other question after the session, please feel comfortable to text us. So, Dr. Rania, over to you now.
thank you so much, ma'am. That's a very wise, very beautiful welcome to me, and a very warm, invite. It's a very beautiful opportunity provided to me to present one of our cases that we and to explain the daily challenges that we overcome in endodontics. I will be sharing my screen now.
Yeah, please.
Is it visible? Hello.
Can you
Hello.
please zoom the screen? Yeah, can you please zoom the screen?
How is it visible now?
No, not now. Please do share it again. Earlier it was visible. Now it's not all visible at
Now?
all. Yeah, it's visible.
Good afternoon, everybody. I'm here. I extend a warm welcome to everybody present here, and also I am here to present a successful case management on a severely curved tooth, that is 4/8. And I express immense pleasure towards everybody who is attending here, as well as thank I say I'm so sorry for that. Good afternoon, everybody. I am here to present a webinar on successful management of a severely curved canal, and I extend gratitude towards my HOD and professor, that is Dr. Siraj Pasha, as well as for Epistate Health for providing me an opportunity to present this case and also recognizing my case, as well as providing me a platform to present one of my cases, as well as showing me as well as giving you insight on the daily challenges we overcome in endodontics. So, going on with the presentation. This let's take a time travel towards 2005 when I really dreamed about being a dentist. I think the little Rania would be proud of me today. So, introducing you to the case, that is a severely curved canal is usually a challenge for most clinicians. That is, it will present challenges in negotiation, challenges in access and forming ledges and zipping the canals are major problems that will come across when a case is curved. And then this tooth is usually, the tooth number 8 or the wisdom tooth, more commonly known as, is u- is usually extracted because of the anatomic complexity it will pose. But in this case, the patient presented with absence of the posterior teeth, that is the 7 was absent. Therefore, to maintain the because of prosthetic reasons or prosthetic considerations, we had to do a root canal treatment on that. So, what are the various challenges that we come across with third molars? It's immense. Firstly, we get curved canals, and it is placed way behind in the tooth, in the mouth. That is when we place the tooth, when the tooth is placed in such a way that when we try to access it, it is way behind, and the access to the tooth with instruments or with hand files is very difficult. Then we come across curved canals. That is, we'll be dealing with it in detail, and then we come across its proximity to the inferior alveolar nerve. So it is very close to the inferior alveolar nerve, making it very difficult to, there is no chance of error. So we have to do everything perfectly. Maintenance of working length, clearing all the debris, everything has to be done very, very meticulously to handle it perfectly. Then we come across a lot of C-shaped canals in our third molars. So C-shaped canals usually pose a greater difficulty during preparation and obturation. So that has to be dealt with. And calcification, when they occur, obviously it is very difficult to negotiate calcified canals. So that take a longer time for us to negotiate as well. So, coming to curved canals can be measured. Like if we see a curved canals, usually all the teeth are curved. There's no root canal that is straightforward or a straight line. So every root canal we come across is slightly curved. If there is a curvature which is less than 10 degrees, it is usually considered to be mild curvature or an easy root canal. While if we come across root canals which are more than 20 or 10 to 30 degrees are usually higher, they have a higher curvature, and they are of medium risk, as well as higher than 30 degrees are considered very severely curved and usually are harder to manage. So if we 1 minute. So if we see, this is Schneider's method of measuring a curvature. So if we draw a line from point A to point C, that is from the orifice of the canal to the initial curvature, that is the point C, and then draw a line from the apical foramen to again intersecting the previous line to point C, and we measure the angle, that is the Schneider's angle that is found, and that will tell us the amount of curvature in the canal. There is another method where we can see curvatures, or we can measure curvatures, is through the radius of a circle. So this is the radius of the circle. So if I draw a circle along the curvature of the canal, so if the circle is less than 4 degrees, it is severely curved. If it is between 4 to 8 millimeters, that if the radius of the circle is 4 millimeters, it is very severely curved. If it is 4 to 8 millimeters, it is mild curved or moderate curve. And then if it is greater than that, it is mild curvature. Okay, so we can measure curvature based on this, and there are various apps also, that EndoPrep app and all of this, that can help us in determining the difficulty in a root canal treatment. So now coming to the case report, this patient presented, this case will be present is on 4/8 on a male patient which has severe pain on the mandibular right tooth. So the case history, the patient came to the hospital with severe pain and discomfort on the lower left, on the lower right back tooth region. And the patient told that he had pain for weeks, and then that pain subsided, and suddenly in the last 3 days, it exacerbated to be very a lot, and it was more during the night and while eating food, all that. So coming to the clinical evaluation, that is when we examined the patient clinically, we saw that there was deep dentinal caries with respect to 4/8, and also there was tenderness on percussion and palpation of that tooth. When we tested the tooth vitality using endofrost, there was no response from the pulp that will confirm that the pulp is necrotic. So now coming to the X-ray, when we observe the IOPR, or the intraoral periapical radiograph, we can see that there is two ways. Like when you observe the X-ray, we observe it 2 times. First is the diagnosis time. When we observe it during diagnosis, we observe a certain aspect. That is, first, the depth of the caries. So the depth of the caries, is it involving the pulp? Is it not involving the pulp? The canal, the pulp canal, there is, and then the infection that will occur at the periapical area. So in this case, we can clearly see that there is inflammation or infection occurring in the periapical area. That is more than two. There is destruction of the lamina dura, and there is inflammation in the surrounding bone. There is radiolucency in the periapical area, and also so this we can say that there was there was the periapical radiograph showed that there was periapical infection. So coming to the diagnosis, we came to a conclusion that was symptomatic pulpal necrosis with apical abscess. So the treatment was, we decided a treatment on retaining the tooth instead of going for an extraction, because it was prosthetically important, as well as going for a non-surgical root canal treatment with to preserve the tooth and relieve pain. So under the treatment procedure, first, as soon as we see a tooth, so I told you about the diagnosis purpose of a radiograph. So now we'll go to a treatment aspect of a radiograph. So when we observe a radiograph for and going into a root canal treatment, what all we observe for? First is the pulp chamber, whether it is calcified, not calcified, and all of that. So it will ease our axis. And then we have the direction of the loss of tooth structure. So we can see here mesio-occlusally there is a lot of decay. So that will be our point of access for the root canal treatment. So the first pulp chamber, first pulp horn that might be exposed will be mostly the mesial pulp horn, where we remove caries. So next, the curvatures in the canal, and as well as the anatomy of the curvatures in the canal can be observed in the radiograph. So coming to the treatment procedure, once all of this is taken into consideration, we go into anesthesia and isolation. So the patient was given lignocaine hydrochloride 1:80,000 with adrenaline, and then it was isolated with a rubber dam. And there was complete pain management, since the tooth is already necrotic, as well as the local anesthesia did its work. Then we have access cavity preparation. So when we come for access cavity preparation, first we go for complete caries removal. We remove the whole of the caries and we expose the nearest pulp horn. Then once the nearest pulp horn is exposed using our round burr, we go for an inside out motion to remove all of the roof of the pulp chamber. So we remove the whole roof of the pulp chamber causing exposure of all the canals. We also refine the access cavity using endo-Z burr or a safe-ended. We can also use safe-ended burr, which is a carbide burr with non-cutting tip. Then we use DG16, which usually makes the work easier. With DG16, we can just locate the canals. That will be easier for us to observe. And then the access cavity, when we opened up the access cavity, we located two canals, one mesial and one distal. This was done under 3x magnification. So coming to consideration of a curved canal in different aspects. So if I have to say you that we have different aspects of managing a curved canal, first we come to access cavity preparation. So when we see a curved canal, we try to make a more straight line axis. This is said for every case, but removing all coronal interferences is very important when it comes to curved canal, so that the initial part of the root canal, that is very straight for us to access. Then once that is done, we go for coronal flaring. So you can see in the first image, the circle, the radius of the circle is smaller compared to the radius of the circle after coronal flaring. So once we do coronal flaring in a root canal, we can remove all the coronal interferences as well as remove overhangs and open up the canal coronally so that we can access the more curved apical part easily. So for this, I used the VS file and coronally flared the root canal so that I can access the more curved apical part easily. So canal negotiation. So once I see that any case we have to use a pre-bent file. So it is more preferred to use a pre-bent 10K or 8 10K files to negotiate canals than a straight not or not a pre-bent file to negotiate, especially in curved canals. When we pre-bend the file and the stopper can be adjusted to the where the bend is already present and inserted into the canal, and slightly used what we use watch winding motion slightly and apical pressure in to push the file into the canal and negotiate it easily. So this pre-bending of the file is a very important aspect in curved canals. So coming to working length determination. So once we negotiated after the coronal flaring, we negotiated the canal and with a combination of 8 and 10K files. Then the working length was determined with J. Morita's root ZXI apex locator, and a X-ray was taken to verify the working length. So the mesial was 19 mm and the distal was 20 mm. So coming to, before I go into the details of the file preparation and all, I would really like to appreciate the product that I've used. That is Epident files. Firstly, they come in a box that is well encased and already sterilized. And even if I want to re-sterilize them, I can place all of the files in the box and again sterilize the whole box. It is sterilizable. As well as it comes with a scale that helps me measure those files very easily. As well as now when I do the preparation, the coming to the files, we have a triangular cross section and all the files are of variable taper. So we have files prepare the apical part separately and the coronal part separately. This will avoid the file to get locked in the canal as well as causing file breakage. So this is an advantage of the file, as well as having a 19 tip diameter in the coronal flaring file has also that is 0.19 of tip diameter, helps the file to go into the canal very easily and coronally and flare the canal in the aspect very easily. So coming to this is the X-ray for our working length determination. Then coming to canal preparation, I prefer filling the canal with hypochlorite as soon as the access is open. So once I do an access opening, I fill the canal with hypochlorite and then I start after the coronal, I put the file into the canal. So every file that goes into the canal carries hypochlorite with it, as well as the disinfection of the canal happens, and also it acts as a lubricant for the treatment. So now we have the S, the V1 and V2 files. The V1 and V2 files are designed for coronal coronal preparations. That is, the S1 file prepares the coronal aspect of the root canal. That is, this aspect of the root canal is prepared with the S1 file. The S This aspect of the root canal is prepared with the V1 file. The V2 file is used for the preparation of the middle third of the canal. And then we have the VF1, VF2, and VF3 canals. VF3 files that prepare the apical part of the root canal. So we have so I don't prefer using RC Health or any kind of EDTA gels, because according to various studies, it says that these gels usually block the flutes of the canal, I mean, flutes of the files, which will cause file separation. So these are the shapers. As I told you, the shapers prepare in the coronal one third and the middle one third of the canals. The finishers prepare only in the apical one third, which will help us to prepare the canal in a much easier manner. Also, you can see that the engagement of the file of the finishers is not visible in the coronal one third. They are only preparing in the apical one third. So coming to fatigue with endodontic instruments, there are two types of fatigue that will usually occur with endodontic instruments. That is torsional fatigue and cyclic fatigue. When I come to a torsional fatigue, means it usually happens with curved and calcified canals. So when I have a curved canal or a calcified canal, mostly this we can see that the apical portion of the file will be static, or it is held on to. There will be a taper lock that occurs in the apical portion of the file, and the coronal portion continues to rotate. This will cause breakage of the file at the point of lock. Then we have cyclic fatigue. In cyclic fatigue, we have this usually happens with curved canals. As we see, there is an inner arc of the root canal and an outer arc of the root canal. So the inner arc compresses the file while the outer arc stretches the file. So when this happens continuously with compression and tension, there will be a break or fatigue of the endodontic instrument. So again, as I told you, AEE classified curvature based on if it is 10 degrees or lesser, it is slight curvature with average risk of breaking a file. Moderate curvature usually occurs from 10 to 30 degrees, and then severe curvature is greater than 30 degrees, and usually in S-shaped canals. So chemical disinfection. So already we mentioned about hypochlorite, how it helps us with the preparation of the canal as well as disinfection. So the moment we enter the access cavity preparation, we place hypo into the canal. We prepare the every time we place a file into the canal. That is, V1 is used, and then we replenish the hypo into the canal. Again, V2 is used to replenish hypo canal. F1, F2 is used. We replenish after each instrument is used, as well as recapitulation was done with a 10K hand file. And then after the whole, and we used a flexi tip to reach the apex, since it was a curved canal, as well as it has a side vented opening, which will also prevent extrusion of any amount of irrigant out of the canal, because it's a mandibular third molar. It is more close to inferior alveolar nerve, and we don't want any extrusion in that area. Then after the whole protocol is followed and the canal is prepared till F2, we go for uh, activation of our irrigant. We replenish the whole root canal system with our irrigant, and then we activate this irrigant we activated it using a sonic irrigator. So there are three modes of our irrigator. We use the high mode to activate the irrigator for sodium hypochlorite. We use for 20 seconds it was activated. Then we rinse the whole hypochlorite with saline, irrigated with EDTA solution, and then we rinsed for again 20 seconds each canal, and then rinse that off, and then we went for placement of calcium hydroxide into the canal for 7 days. It was placed for 7 days since there was a periapical lesion. So once the patient returned back after 7 days, the whole of the calcium hydroxide was removed using irrigation, that is using saline and hypo irrigation. Again, activation of the irrigants was done. Then we went for a cone fit check. Apical, we also checked for the apical patency using a 10K hand file. Then we checked for apical tuck back. We used a 25K file to go till the apex and checked if there is a snug fit of the file into the canal. So when we have a snug fit for the file into the canal, it is the GP also snugly fits into the canal to form a proper apical seal. So once that is done, we placed our GPs into the canal and took a periapical radiograph. Once that is confirmed in the radiograph, the sealer, AH plus sealer was used, and it was placed into the canal. Once it was placed into the canal using lenterospirals, we use the sonic irrigator on the low mode to make the irrigant, I mean, sorry, to make the sealer flow into the canal till the apex. Then we place the GP into the canal and sealed it. And then we sealed till the middle one third. And then the whole thing was from the middle one third. We removed the GP as we used vertical compaction with Gatapacha to seal the coronal one third. So we are so used to seeing anatomical variations in the greater part, that is more than 3 canals and more than 5 canals, that when we come across a 2 canal or a single canal case, we are like astonished. We want to find more, so we look for more canals. So according to various literatures, it says that root third molars usually have two canals in 29.4 cases in an American population. Then there was another study that said that the third molar also had 55.6% of root canals had 2 canals in the third molars. So these all studies confirm that we also did access refinement of this root canal with ultrasonic to check if there is any extra canals, but we found only 2, and we obturated them using warm vertical compaction. So coming to the end of so this is the end of my presentation for the case. So coming to the key takeaways from this case presentation, first is accurate diagnosis. As my HOD always says, we have to have a endodontic eye to look at a radiograph. So when we look at a radiograph with an endodontic eye, we observe for calcification, we observe for curvatures, we observe for deep splits and all of that in the root canal system. And also we have to know literature behind it to understand what we are seeing. That is, the eyes does not see what the mind does not know. So coming to the irrigation of the root canal system. So irrigation is a vital aspect of root canal system. So if we do not perform a proper root canal treatment, root canal irrigation, the biomechanical preparation has to have a proper irrigation protocol. If the irrigation protocol is not followed properly, the healing of periapical lesions usually are not that successful. So we have to follow that using ultrasonics. There are various irrigants that have come across nowadays, and also there are a lot of activation systems like our ultrasonics, sonics, laser light activation, and all of that. So coming to intracanal medicaments, when we have placed, once the canal preparation is done, when the patient is having a lesion in the periapical area, usually calcium hydroxide is used as intracanal medicament. It has a high pH, and also it has a pH as well as antibacterial activity that will prevent proliferation of bacteria in the root canal system. That's why using an intracanal medicament, especially when there is periapical lesions, is a must. So apical seal, we have to make sure once we prepare a root canal, if usually it is preferred to do it is mandatory to do a recapitulation with our hand files, or do a recapitulation with a file that is of previously used, so that we maintain apical patency and avoid dentine chips accumulation at the apex. So if these dentin chips are accumulated in the apex, it will have the smear layer, it will have debris, it will have microorganisms. All of this can promote inflammation in the periapical area. So it is very important to maintain apical patency and uh, um, avoid a lot of debris accumulating in the apical area. So once we clear all of that, we have to place our GP and check for a tight apical seal and have a proper tug back for that particular GP that we are using, or we have to prepare the canal once more with the same file or with the higher number file to get a proper tug back for that root canal system. So three-dimensional obturation, once we seal the apical aspect in with a proper file, we can use warm vertical compaction for uh, filling the canal completely with GP. So that there is so that we don't leave empty spaces which will help which will make bacteria proliferate in that area. So once we achieve a proper apical seal, it is also recommended that we go for a coronal seal that is really intact. We have like coronal seal usually is not, we see that the apical seal happens perfectly, but we don't usually take care of the coronal seal. It's usually temporary, or as the patient is sent back sometimes that causes a lot of leakage of bacteria and saliva into the canals, causing reinfection. So as soon as we do a root canal treatment, it is preferred to use GIC in the apical or in the pulp chamber, followed by another that is composite in the coronal aspect that of the this of the root canal system, that will help us seal the pulp chamber as a whole. So to conclude, this case highlights the importance of precise diagnosis, careful endodontic treatment, and adequate follow-up in managing a root canal treatment. Advanced imaging such as RCBCT, as well as the modern root canal instruments that are very flexible, that use use night eye technology, as well as they have shape memory and elasticity that will help in preparing curved canal as well. Like Epident V Plus also is a night eye file system that helps us in preparing the root canal system which is highly flexible and goes into the canal and prepares even the curved areas that contribute significantly in achieving uh, favorable outcomes in challenging cases. So these are my references. Thank you so much.
Thank you, Dr. Rania. It was a wonderful presentation, very nicely explained. And I really appreciate the way you explained about the canal curvatures. You described the canal curvatures, how to assess which is the difficult one, which is the easy one. You know,
Thank
how
you
to
so much.
assess the canal curvatures and accordingly choose the files. Yeah, it was a
Yeah.
wonderful presentation coming from a postgraduate student. It's so good to see.
Thank you so much.
Congratulations once again on your wonderful work. And
Thank you so much.
just a small doubt. Okay, so now just wanted to know what is your take on endodontic management of mandibular third molars? Should we go for extractions or should we save?
Ma'am, it depends. See, if a tooth is completely erupted in the dental arch, we have the opposing tooth, and we have, all the aspects of the tooth favor the tooth to be in the canal. That does not require extraction. If the tooth is causing problem to the adjacent teeth, like causing impaction, pain, discomfort, or it is also accumulating a lot of food and debris in that area, which will cause disruption for the seventh, that we can go for extra. It depends. Each case has a different scenario. So if a patient comes to me with a tooth that is even decayed, maybe eight, but it is functional and also placed in a right position with the opposing teeth functional, then I don't think so. It requires extraction. Also,
Absolutely.
anatomical consideration has to be taken.
Absolutely. Once I attended one endodontic talk by a very famous endodontist. That was long back, 10 to 15 years back. And he mentioned that there is no absolute contraindication of endodontic, except
Yes,
when the tooth
except
can't be restored.
restored. Yes.
Yes. So
Except
even I
no rest,
believe,
like, yeah.
yes,
If the tooth cannot be restored, only
restored,
then it has to be
then it has
extracted.
to be extracted.
Otherwise, it can be
Otherwise,
retained.
it can be saved.
It has to be retained.
Absolutely. Absolutely. So thank you so much, Dr. Rania. I doubt there are any questions, but yes, so good that you have shared your contact details with us. So if anybody has questions, please feel free to contact either me or to Dr. Rania.
Yes.
Thank you so much, Dr. Rania. And once again, before leaving, I'm so proud to share this on behalf of our company, Epistate Health Singapore. Just a minute, please. Uh, Thank you so much, Dr.
Thank you so
Rania.
much, ma'am. Thank you, ma'am.
Thank you so much.
Thank you.
It was a meticulous presentation. And so next Sunday, we are coming up with another episode of One Among You, where our speaker will be Dr. Justin Eldo. And just to tell you one very important thing, I'm so sorry I missed this out. Dr. Rania recently won third prize in beginner category in a case contest that was organized by Epistate, and this was the chosen case. So congratulations, Dr. Rania.
Thank you so
Congratulations
much,
once
ma'am.
again.
Thank you.
Yeah, thank
Thank
you
you.
so much. And keep sharing your cases with us. And we would love to see your cases, especially done
Yes.
with our file systems. So if you have any suggestions, I mean, your team, your staff, please
Yes, ma'am.
discuss. Feel free to discuss with your teachers. And please let us know. We are welcome. We are open to do the necessary changes. And keep
Yes.
posting
For
your
sure.
cases on social media and do tag us.
Yes, ma'am. For sure.
Okay. Thank you so
Thank
much.
you so
Take care.
much. Thank you.
Bye.
Bye bye.
Bye. Bye.